Well, good evening and welcome to our third session in our vaccine online course. Last week we covered some interesting concepts linked to vaccine development and also vaccine implementation. This online course is a collaborative effort between the Center for Evidence-Based Healthcare as well as Becky Cisa. And this week we will be having two sessions. Tonight's one on vaccines and variants. And then on Thursday, we will cover a session on COVAX. So I'm really delighted to be introducing you to our speaker for this evening. Prof. Marianne Davies is a public health medicine specialist with a lot of experience and work in the area of epidemiology and surveillance. She's the director for the Center of Infectious Disease Epidemiology and Research at the University of Cape Town. And she will take us through a session on variants and vaccines. Just a reminder on some of the housekeeping, please keep your videos off and your microphones on mute. You are welcome to post comments and questions in the chat as we go along. And following the presentation, we will then enter into the question and answer session where Anal will be able to summarize and pose the questions that you've put in the chat to Marianne. Marianne, warm welcome to you and over to you.
Thanks very much, and thanks for the invitation to do this talk on variants and vaccines, which has been really helpful for me as well, because it's helped me to kind of really freshen up my understanding of how variants emerge, what is the impact on vaccines, and to think through what we could possibly do about it. Just to confirm that you can see my video, if I can just confirm that before I continue.
Yes, all fine.
Fantastic, thank you. So I think we all know towards the end of last year, we heard alarming news from several places in the world about variants, and these really made the headlines. And it was to these variants that was ascribed the increased transmission that was seen, particularly in the UK, also in South Africa, our second wave, and more recently in Brazil. And so what I'm going to try and cover in this first half of this talk is the issue of why do we have variants and why do we have them now? And as a way of warning, it's going to require a little bit of biology. So for those of you who perhaps have a biological background, you might find this terribly easy. For those who don't, and I myself didn't do biology at school, and I always struggle a little bit with the basics of biology, I'm going to try and keep it really basic, but I think it is important to understand a little bit of the biology at a high level, just to be able to really understand how variants emerge and what we can do about them. The second part of the talk, I'm going to touch briefly, because I think it's important for journalists to know how we should call variants, and then what do they mean for vaccines and what can we do about it. So to start off with, why do we have variants and why do we have them now? And there may be some people on this call who don't believe in evolution, and if there is anybody, I'm going to ask that you suspend that disbelief in evolution for the sake of this call, and that you allow yourself to believe in evolution, because really understanding variants takes us back to Charles Darwin and his Origin of the Species and the principles of evolution and how species evolve. In this case, of course, how viruses evolve. So,
Marianne, I'm sorry to interrupt you. Can you maybe just turn your volume up a little bit?
I can try. I can also just use a different speaker. Just hang on a second. Is that better?
That's excellent. Excellent. That's
okay. Sorry.
Thank you.
That's fine. I think my headphones weren't working properly. That's fine. So the principles of Darwin's evolution are really what we're going to be thinking about here. And there's a very nice example, which is the peppered moth, which exists in the UK and Europe. And I'm going to talk a little bit about the peppered moth and then talk about the principles of evolution. So the peppered moth comes in a range of different shades, as you can see in the picture on the left-hand side. And that's the first principle of evolution, that individuals are all different. We also know that people, for example, are all different, and that we pass our characteristics on to our offspring. So the peppered moths that are paler in color will pass on pale characteristics to their offspring, and the darker peppered moths will have darker offsprings. So that variation is inherited. Now, what happened is that initially most peppered moths were quite light in color. And that's because, as you can see in the tree on the right-hand side, the trees are covered by lichen, and the pale moth on the right-hand side is quite difficult to see. And because these moths are eaten by birds, it's very difficult for birds to spot the moths that are very pale, but much easier to spot the dark moths. So for a long time, most moths were actually quite light in color because that gave them a survival advantage because they were harder to spot and be eaten. During the Industrial Revolution, what happened is that the trees all went black and became dark. And so those pale moths no longer had a survival advantage. And instead, the dark moths started to survive. So the variability or the variation of moths that was dark had a survival advantage, and they lived long enough to reproduce. So they had a reproduction advantage. And under the selection pressure of the dark trees, they were able to survive. And what we found was that the population changed from having mostly pale moths to having mostly dark moths because they were advantaged, or in biological terms, more successful. And that's really what we mean when we talk about survival of the fittest. What's very interesting about the peppered moth is that there was later legislation passed which stopped the amount or lowered the amount of pollution, and the trees turned white again. And the dark moths started to disappear because they were no longer advantaged. The selection pressure had changed, and we went back to having paler peppered moths. So viruses do exactly the same thing, but we often think of this evolution as being something that happens quite slowly, whereas in the case of viruses, it happens really, really fast. What I'm sure you've all learned over the course of the last year is that viruses enter our cells, they take over our cellular machinery, and they make loads and loads of copies of themselves, and they do this really quickly. So the reason that they can evolve so quickly is firstly because they have a short generation time. It doesn't take long for viruses to produce lots and lots of offspring, unlike us who have to grow to sexual maturity, and then we have to become pregnant, and then it takes 9 months to have a baby. Viruses in the space of a day can make lots and lots of copies of themselves. Also, whereas we might have a few children, viruses make millions of offspring. And so every time they're making copies of themselves, they're passing on that variation, like we saw in the peppered moth, to their offspring. The third thing is that more complex organisms like us are very careful when we replicate to try to avoid making mistakes. So our genetic material tries very hard not to make mistakes and has a number of mechanisms that prevent it from making mistakes. Viruses don't really care about making mistakes. All they care about is quantity rather than quality. So when they replicate their genetic material, they have what we call error-prone replication, which means that they're likely to be mistakes and that the genetic material is likely to change. And this is particularly concerning if we have lots and lots of transmission. So if the virus is being spread to lots of people, because we then have a combination of lots of offspring being made and lots of mistakes being made, and the possibility for a virus to change very, very quickly. So this is illustrated very well by HIV, which you may be familiar with, and many of you may have heard about the fact that HIV develops drug resistance very easily. This is a cartoon picture of a number of HIV viruses in somebody's body. And you can see that most of them are the same, but that there are some that look a little bit different. So in most cases, that wouldn't be an issue. But if we give someone antiretroviral drugs, you can see here we've got 3 different types of HIV, and we find that the drug stops replication of viruses that are susceptible to the drug. Those HIV variants will disappear, and instead the virus that can develop a mechanism to be resistant to the drug will multiply and take over. So essentially what we've got here is Darwin's principles. We've got variability in our population. The variation gets inherited, it gets passed on to the next generation. We have selection pressure because we're bringing in drugs that can stop certain forms of the virus from reproducing, but that the virus which has mutated to allow itself to reproduce despite the drug is advantaged, and ultimately those successful variants predominate. The way we deal with this with HIV is to give 3 drugs at the same time, because it's very difficult for a virus to mutate in such a way that it is able to resist 3 different drugs. It would have to develop 3 different mutations that enable it to escape from those drugs. And usually the natural form of the virus, or what we call the wild type of the virus, is better able to replicate. And each time it mutates, it makes it a little bit harder for it to be able to replicate and produce those millions of copies of itself. And so if it's got to kind of twist itself around to be able to avoid 3 different drugs, it's really difficult for it to be able to do that. And so we tend to not get the development of resistance. So that was a sidebar into HIV, but now what we're going to do is to look at how this all works with coronavirus or SARS-CoV-2. So here we've got a picture of a coronavirus, and on the outside it's got a capsule, it's got these proteins that stick out, which are called the spike proteins that I'm sure many of you have heard about, which help it to bind to our cells. And inside, all that is inside a virus really is genetic material, which is the code or the blueprint for it to make copies of itself. In the case of coronavirus, this genetic material is RNA, and it's made up of building blocks, which we call bases, and there are about 30,000 of these. So if you had to lay it end to end, you've got about 30,000 of these building blocks. And each of these building blocks can be one of 4 things, and you don't need to worry too much about these names, but it's important to know that there are 4 possible of these building blocks, which are, the names are adenine, cytosine, uracil, and guanine, but you don't really need to know too much about that, except to know that these building blocks are laid end to end in a long chain to form the genetic material of the coronavirus. 3 of these building blocks will code for an amino acid. So they will make an amino acid, and then multiple amino acids will make up the proteins that are in SARS-CoV-2, in the virus. And so essentially the important thing to realize is that there are kind of 3 steps here. We've got the RNA, the genetic material. That RNA gets turned into amino acids, the second step, and a string of those amino acids together forms a protein, and those proteins form the coronavirus, like the spike protein and the capsule. So it's really a little protein package with genetic material inside. And so different parts of that genome are going to be responsible for coding different proteins. You can see this section of the genome is responsible for coding the spike protein, and there are other components that are responsible for coding for different other proteins. Now, what happens is that these building blocks, these genetic building blocks, undergo spontaneous mutation every time the virus replicates. So every time it changes, there can be a little bit of a change. So if, for example, you had in this order, like we've got in this chain, this set of bases, you could get what we call a point mutation, which is a single change from a G to an A. And you can imagine, because 3 of these code for a particular amino acid, that could result in a different amino acid being produced and therefore a different protein being produced. The other thing that can happen is that whole sections of the genome can either get deleted, or you can get an insertion like this, where we've had an added AAUU. And again, if you imagine your 3 sets of 3, you're going to get a different amino acid being produced and therefore a different protein being produced. But it's a little bit more complicated than that, because what we find is that actually there are multiple combinations of these bases that can code for the same amino acid. So it doesn't have to only be a GCG that codes for a particular amino acid. It can sometimes be a different combination. It's a little bit like having different recipes for chocolate brownies, but the end product is still chocolate brownies. So often you can have mutations which don't make a difference, and they still result in the same amino acid being produced and therefore the same protein. But sometimes what happens is that the mutation does make a difference, and instead of getting the same amino acid, or instead of getting chocolate brownies, you get something completely different, like milk tart. And we call these meaningless mutations if you get the same thing being produced, and meaningful mutations if you get something different being produced. So to summarize, these mutations happen all the time. And coronavirus actually mutates quite slowly. Of those 30,000 bases, those Gs and Us and As and Cs, they're usually only about 2 changes per month. So it's not very fast. And in fact, we didn't see much mutation in coronavirus until October of last year. Flu mutates about twice as fast, and HIV mutates about 4 times as fast. So coronavirus is definitely not a Ferrari in terms of mutation and evolution. As I've said, many mutations make no difference. So often we're still getting chocolate brownies, even though the genetic material has mutated, but some of them do. And those result in something different, like milk tart. If we don't have any selection pressure, the mutations happen pretty randomly. And so what we would expect is a similar frequency of meaningless mutations, mutations that still result in the same protein, and meaningful mutations, mutations that result in something different. But if we have selection pressure, it means that there's something driving the virus to change, and we would see an increase in the number of mutations that actually make a difference. And that's exactly what we saw in November last year. So what this graph on the left-hand side is showing is essentially the number of meaningful mutations, mutations that made a difference to the proteins that were produced, that happened over time since the start of the epidemic. And you can see that for a number of these proteins, suddenly in October, around the world, everywhere, there was an increase in the number of changes in the genetic material. And this corresponded to the time when several variants emerged. So although those variants were announced in December and January of this year, they were actually from specimens that were tested in around October and November. And so those all emerged at the same time in different places in the world. And we also saw similar mutations like the 501Y V2, which I'm going to talk about, happening in these different viruses. So that's what we call convergent mutations. The same mutations were happening in totally different places in the world. That wasn't due to travel, because we didn't have a whole lot of travel happening. It wasn't that the virus from South Africa went to the UK and caused the changes there. It happened independently in a lot of places in the world, which meant that there was something happening a little bit like what happened to the peppered moth all over the world to make the coronavirus try to change. So what happened? Well, we know for the peppered moth, it was because of the pollution and the change in the color of the tree. What changed for the coronavirus? We don't really know, but there are a couple of possible explanations. The one thing is that we had a growing population of people that were immune, that had already been infected. And I'm sure many of you have heard the story of Manaus in Brazil, where they had this very, very high proportion of the population that was immune, but they still got a second wave. And with this high number of people that is immune, if a virus could mutate to escape being recognized by the immune system or to be able to reinfect people, that would definitely give it an advantage. So this pressure of growing immunity, but still having ongoing transmission, gave the virus an opportunity to really favor mutations that would allow it to escape from our immune responses. The second thing is that it was around that time that a lot of countries were opening up, and so we had increased transmission. And if you think about the virus and the idea of more is more and making lots and lots of copies of itself, when the virus, when we opened up and allowed gatherings and people became tired of COVID and stopped wearing masks and stopped worrying about social distancing, that allowed the virus to spread, allowed it to make lots of copies of itself. And so that also favored change, because we had lots of virus spreading around in the context of this growing immunity. And the third thing, which is probably not so important in our context, but is important for just understanding how these mutations happen, is that some people have been shown to be chronically infected with COVID. So instead of having COVID for only 10 days and then clearing the virus completely, they continue to shed and have replicating virus. Now, if you think that the virus came into human population in January of 2020, it obviously took a while for people to be infected for long enough for them to start accumulating enough mutations for those mutations to be important. And so it was probably in around September or October that we had enough people who had been chronically infected. And obviously, as the virus was making copies of itself inside their bodies, it was mutating, and they might develop a different type of virus. What's particularly interesting is, particularly in the UK and the US, there are examples of patients who were chronically infected because they were immune suppressed, and they were given immune treatment. In other words, they were given plasma from other people who had already had COVID. It's called convalescent plasma, plasma from people who had recovered, in order to try to help them to clear the COVID in their own bodies, because they didn't have a functional immune system. And what they found is that in these people in particular, they found a number of mutations similar to the ones that we see in the variants. So what this shows us is that if you put immune pressure, if you expose the virus to antibodies or to the immune response, that it is actually able to mutate. This doesn't happen in healthy people, people with a functional immune system, because they're able to clear the virus. But for people who are chronically infected, the combination of a virus that's continuing to replicate, together with the convalescent plasma, the immune pressure, allowed these mutations to develop. And this hasn't happened only in people, but it's actually been shown to happen in the laboratory as well. What they did was they took virus and they grew it up artificially without antibody, and then with antibodies that they'd taken from people who previously had COVID. And you would expect that the antibodies would completely suppress the growth of the virus, but they didn't. These little light green dots are the bits of the virus that could grow without the antibodies, and they're shown here, just exaggerated. And when they actually looked at these little viruses, they found that those viruses had mutations. So the antibodies were putting selection pressure onto the virus and resulting in populations that could escape from the immune response. To go back to this explanation around what changed, and what changed particularly at the level of the population, you may remember that it was actually in October that many people were proposing that we should actually really allow this virus to spread, because the only way to cope with this disease was to reach herd immunity, which would then protect, so if we got enough people in the population immune through natural infection, this could interrupt transmission of the virus. And that was kind of consolidated in a group of scientists and epidemiologists who made what was called the Great Barrington Declaration. Said we shouldn't have all these lockdowns and shutdowns and all these restrictions, and we shouldn't bother too much with mask wearing. We should allow this virus to spread so that lots of us can get infected and then become immune, and that can interrupt transmission. In retrospect, that probably wasn't a very good idea. And although the people who opposed the Great Barrington Declaration didn't articulate this at the time, what actually happened was that we had that increased transmission happening, and at the same time, a growing population of immune people. And that combination of some of the population being immune, but still having lots of transmitted virus, may well have created the necessary selection pressure to create an environment where it favored these variants to emerge. And I think this quote by Anthony Fauci puts it very well, that the more humans get infected and the more we allow transmission to happen in the context of growing immunity, the greater the chance is that this virus will figure out how to outwit us and adapt itself to humans. So what would give a virus an advantage in this context? Well, obviously in the context of growing immunity, a virus that's able to evade the immune system, that looks different, that arrives in disguise or incognito, is going to be very helpful for the virus. It's going to allow it to continue to transmit despite the fact that we have immunity. Secondly, a virus that can transmit more easily is going to have an advantage. It can spread more easily. That's definitely going to give it a survival or a fitness advantage. How could a virus possibly change to be able to transmit more easily? Well, it might be able to produce more particles of itself. It might be able to, when it replicates, to replicate more efficiently and make more copies of itself. It might live for longer, so that people are actually infectious for longer and they have a longer period over which they can spread the virus. Or it might become better at entering human cells, so that if you're exposed to the virus, the chance of you becoming infected is much greater. And we know that one of the mutations that we have seen is in the spike protein of the virus, which is the part of the virus that binds to the human cell, and that it is thought that the mutated virus is actually able to bind to human cells better than the wild type or the original virus. Now, the virus does all of these things, and these mutations are favored because it wants to transmit better and it wants to survive. What it doesn't really want to do is to make people very, very sick, because if you're very sick, you tend to isolate yourself, go to bed, get admitted to hospital where you can't spread disease, or you may even die and then you can't spread disease. But sometimes, as a byproduct of producing more particles and being better at entering human cells, the virus does actually cause more severe disease, and the survival benefit of doing these things that increase transmission outweighs the fact that as a byproduct, it causes more severe disease. And so, for example, the UK variant, or the variant that first emerged in the UK, does seem to cause more severe disease. We don't know yet for the South African variant. Initially, it looked like it probably didn't, but there's now some emerging evidence that at least we saw higher mortality in the second wave compared to the first wave. And so we need to investigate whether that is because the variant caused more severe disease, or whether that's just because our health services were under so much pressure in the second wave that we couldn't cope. But I think the important thing here is that generally causing more severe disease doesn't give a virus a survival advantage, because the host, the human, will then isolate themselves, get admitted to hospital, or die, where they can't spread the disease. But sometimes, because the virus has to change to increase its transmissibility and do things like produce more particles or be better at entering human cells, a kind of byproduct or an unintended effect of that might be that it actually also causes more severe disease. So that was the biology, hopefully soon over, about why we have variants and some of the thinking around why they have emerged now. The next thing I want to cover is what should we call variants? And the naming of these variants has been incredibly challenging, so much so that Tulio de Oliveira, who's become a household name, said it's a bloody mess. It's very difficult to name these viruses because there's a tension between being scientifically correct, and you can see the scientifically correct names for the variant that emerged in South Africa on the right-hand side, and they definitely don't roll off the tongue. And it's very easy to get one of these letters and numbers confused and call it completely the wrong thing, compared to a name that is memorable and pronounceable. So if we're being scientifically correct, even if we want to do that, there are two ways that we can be scientifically correct. The one is we can refer to the functional change. So what amino acid has changed, which is what the 501YV2 does. Or we can refer to the ancestry. Where did this virus come from? What was its ancestor? The problem is that, for example, we've seen this functional change in 3 different places in the world, in the UK, in South Africa, or it's emerged in 3 different places in the world, the UK, South Africa, and Brazil. But those 3 viruses have completely different ancestries. So you can have the same functional change requiring a name that looks something like this in 3 different lineages, or 3 different, if I can call them, families of virus, giving them a completely different name. So the UK one, for example, is called B1.1.1.7, and the one that emerged in Brazil is called the P.1 virus, something completely different, which wouldn't tell you that functionally they might actually be similar. So in the context of all this confusion, what we tend to do is the worst possible thing, which is to name them after the countries that they've arisen in. And this is a newspaper headline that was sent to me from a friend who lives in the ski resort in Austria, in Tyrol, where I think this is the worst reporting possible. I'm sure no one on this call would do this, but they'd literally turned the virus into a South African flag. And he sent me a WhatsApp and he said, "Your virus has arrived." So we tend to then end up calling them after the names of the countries where they emerged. And the problem with that is that it creates stigma. Just like in the beginning of this epidemic, people talked about the Wuhan virus or the Chinese virus, which resulted in stigma and animosity towards Chinese people. And we certainly don't want to name these viruses after countries. If we do have to mention the countries, we should talk about the virus that emerged in a particular place. So what people have tried to do is to suggest that we should focus on trying to combine the functional change with what is memorable and pronounceable. So in the variant, all of the 3 variants that have emerged in the UK, South Africa, and Brazil, one of the big functional change is that an amino acid, which was an N, remember these building blocks in this piece, at the position 501 in the protein has changed to a Y. We as non-biologists don't need to know what the N and the Y do, but that's where the name N, sometimes people forget about the N, 501Y comes from. And then the V1, V2, and V3 is to say which one was announced first. So V1 is the one from the UK, and that was announced first. We have V2 because ours was announced second, and V3 is the one that came from Brazil and was announced third. To kind of compromise and make this easier, some people have turned these into nicknames, which I quite like. And so instead of calling this the N501Y, they've called it the Nelly virus. And that particular mutation is the one that increases the binding to human cells. Another mutation which is present in the variant that emerged in South Africa and the variant that emerged in Brazil, but not in the variant from the UK, is what's been called the EEK mutation, which is very nice, and that's because an amino acid that was an E has been replaced by K at 0.484 in the protein. And it's this EEK mutation, which is the one that's particularly worrying in terms of vaccines, because it allows the virus to evade the immune system. And so it's because this mutation is present in the variant in South Africa that we are concerned about whether vaccines will still work or not, because vaccines are obviously dependent on the immune system. So that takes me to talk about what do variants mean for vaccines. And really I think this is probably revision of the talk that was given by Professor Mohammed at the beginning of this course, is just a reminder of how vaccines work, because that's important for us to understand how variants, why variants are a concern for vaccines. So as I'm sure you all know by now, vaccines introduce a form of the disease into the body, either by coding for a piece of the virus or by giving a weakened or an inactive version of the virus into the body. The body then reacts by stimulating the immune system and creating antibodies, and also having our whole immune system primed. And so when we encounter the actual virus, those antibodies that we've made can recognize it, and they can very rapidly mount a response to be able to fight that virus. And so that's all based on being able to recognize the virus when it comes again. If we have a virus that looks different, and when the body is no longer able to recognize that virus because it's changed, as has happened with the EEK mutation, then it may be that our bodies don't mount that same antibody response, that our immune systems are not stimulated, and therefore that although we've got all these antibodies in our body because of the vaccine, those antibodies from the vaccine are not able to recognize and respond to this changed virus. So what do we know about which vaccines do work and don't work? The most important data comes from clinical trials, which is where the vaccine has actually been given in the context of the variant being present, and we've been able to see whether it works or not. And there have been 3 trials that have been done in South Africa during the period where the 501YV2 variant was present. The Novavax vaccine, and these results were updated, I think, just last week, showed an efficacy in South Africa of 49%, but if you excluded people with HIV, the efficacy was 55%, which suggests that it does work against the variant, but it didn't work nearly as well as it did in the UK, where the efficacy was 89%. So there was some retained efficacy, even against mild and moderate COVID for Novavax, but nowhere near as good as in settings without the variant, so suggesting reduced efficacy. They also found that most of the vaccine failures, so the people who developed COVID despite having the vaccine, were due to the variant, again suggesting that it doesn't work as well. Johnson & Johnson, which is the vaccine that's currently being rolled out in health workers, showed more promising results. They showed efficacy in South Africa of about 64%, and this is a single dose vaccine, and in other settings, that vaccine had about 66% efficacy. So that suggests that the efficacy was not dramatically reduced in South Africa. But again, most of the vaccine failures were due to the variant. What is encouraging is that both of these vaccines, although their efficacy was not that high against the variant, were very effective against preventing severe disease, even due to the variant. And so if we give those vaccines, they can still prevent mortality and morbidity and the severe disease that we've seen, particularly in the second wave in South Africa. The disappointing results came from the AstraZeneca study, which I'm sure many of you have covered. And what they found was that they didn't have anybody in their trial who developed severe disease, but that the AstraZeneca or Oxford vaccine was really not effective against mild or moderate disease, only about 22% effective. What you can see in this graph on the right-hand side is that what you're looking at here is the number of infections in the people who were vaccinated, shown in blue, and the people who got the placebo, the dummy vaccine in red. And you can see that initially the vaccine did seem to work because people who got the vaccine had much lower infections than people who got the placebo. But around the time when the variant emerged in South Africa, that crossed over and essentially the vaccine was no longer protective. So initially it was about 75% effective. After the emergence of the variant, it really wasn't protective at all. And again, most of the failures were due to the variant. So what we really need for all vaccines is either clinical trials that show us whether they work or not, or to actually implement those vaccines in South Africa and to watch very closely to see whether they have an impact on our infection rates. And so we will certainly be doing that when the Pfizer vaccine, which has been promised, is introduced, and we're doing that already with the Johnson & Johnson as it is implemented in health workers. The second clue can be to look not at actual clinical trials, which are expensive and which take a long time to get results, but to look at people who have been vaccinated, to take blood from them, and to expose that blood to the variant viruses and see what antibody responses they develop. So the first one I'm going to talk about is AstraZeneca. And these graphs, the higher the levels are, it shows the more antibody responses you're getting. And you can see that if you took blood from vaccinees and you exposed it to the old virus, you got quite high antibody responses. But if you exposed it to 501YV2, you really didn't get much in the way of antibody responses. They were substantially reduced. The Moderna vaccine, which is the one that was developed in the US, we do the same thing. On the left-hand side, we're looking at responses to the old virus or the wild-type virus, the non-mutant virus, compared to the virus from the UK, the 501YV1. And you can see there that the antibody responses are essentially pretty similar. And that's probably because the UK variant, remember, doesn't have the EEC mutation, the one that allows evasion of the immune system. On the right-hand side, we're looking at responses to the old virus compared to responses to the 501YV2, the variant from South Africa, and you can see that we have the substantial reduction in antibody responses, which would make us concerned that the Moderna virus might not work in our setting. Finally, at the bottom, if we look at the Pfizer vaccine, on the left-hand side, we're looking at responses to the old virus, the non-mutant virus, compared to the virus from the UK in green, 501YV1, and you can see actually, if anything, the responses to 501YV1 are slightly better than to the old virus. But on the right-hand side, when we're looking at responses to the old virus compared to 501YV2, our very special virus that emerged here, we can see some reduction in antibody responses, but it's not that big. And so that makes us fairly optimistic that the Pfizer virus could work in South Africa. But again, we don't know for sure. This is just looking in the laboratory. It's not actually a clinical trial. It doesn't tell us whether it works when it's actually given to people. The other thing that's important is that antibodies are just one part of our immune system. We also have immune cells, particularly T cells, that are an important part of our immune system. And we don't know yet exactly how these measures in the laboratory will indicate whether these vaccines actually work in practice. And this is a huge challenge because we obviously can't do clinical trials in the setting of every single variant that emerges and that will emerge into the future. And so one of the things that laboratory people are trying to do is to identify what we call correlates of protection. So things that we can measure in the laboratory that will tell us whether a vaccine is likely to work in a particular population or not. Lastly, if a virus is able to cause reinfections, that would also suggest that it may not respond well to, or that it may be able to evade vaccine responses. We know that you can get reinfections with all of the coronavirus variants, but if the variants are able to reinfect at a greater rate, then that would suggest that they could evade immune responses. Modeling studies have suggested that there's no greater reinfection risk with 501YV2 compared to the previous lineages of virus. But what we have seen is that if we expose 501YV2 to blood from people who've previously had COVID, that we don't see very much in the way of responses or restriction of the growth of the virus. And that's what this graph at the bottom is showing. Essentially, high values show that the virus is very well restricted by serum from people who've been previously infected. Low values show that growth can happen quite easily. And what we can see is that when we take blood from people who've previously been infected, that they're very well able to contain the growth of first wave viruses, but they're not well able to contain the growth of the 501YV2, particularly if we dilute their blood a lot. So we reduce the number of antibodies or the immune cells that are present, then their ability to contain 501YV2 really drops off, which suggests that the 501YV2 is able to evade the immune response. So finally, what can we do about it? Is everything bleak? And I want to take us back to Darwin, because it's really thinking about Darwin's principles that tells us what we can do about it. You'll remember the first thing about Darwin is that we need to, that there needs to be variability in the population. And so the first thing we need to do is to be able to identify the variants and have very good molecular surveillance so that we can know that variants are emerging. One of the things that has been said is that the countries that have found variants are the ones that actually have the best molecular surveillance. And you won't find a variant if you don't go and look for it. So we need to know that they're emerging and to know what changes are in the different variants, because we may need to change our vaccines to be able to account for the changes in these variants. The second thing is that we know that variation is inherited, and you'll remember that I said for viruses, more is more. And so if we can stop that inheritance by slowing down transmission and doing all the social distancing measures that we know help to reduce transmission, that can reduce the emergence of variants. Part of that is to reduce transmission by doing what our president did and getting ourselves vaccinated once we are eligible for vaccination. Because by vaccinating, we can reduce transmission and so reduce the replication of viruses, which drives the development of mutations. The third thing we can do is to try to change the selection pressure. And I want to take you back to the thought of the antiretrovirals, where we give 3 different antiretroviral drugs. And so what we can try to do is to develop better immune responses to the vaccine. So the vaccines that we're using at the moment are called really first generation vaccines, and what's under development are second generation vaccines, which will be multivalent. So at the moment, most vaccines are based just on the spike protein, but these newer vaccines will be based on several parts of the virus, and they will result in a much better and a much broader immune response. And so it will be much harder for the virus to actually be able to evade that immune response. So we need better vaccines. We need to be one step ahead and smarter than the virus. And the last way we can be one step ahead is that we can actually predict the likely mutations. If we grow up the virus in the laboratory in the context of either sera from people who've been previously infected or from people who've previously been vaccinated, we can see which viruses survive, like these viruses that I showed you before that had grown up in the laboratory, and we can see what mutations they develop. And so we can predict those mutations and use those to develop better vaccines. So I'll just end. I've learned a lot about virology in the last few months, thanks to really many of the virologists who are part of the South African COVID Variant Research Consortium who've been very patient with my lack of knowledge. And I hope I've managed to share some of that with you this evening to really help you understand a little bit more about variants and how they relate to vaccines and our vaccine programs. Thank you very much.
Thanks, Mary Ann. I'll hand over to Anal that will take us through some of the questions.
Thank you very much, Professor Davies, for an excellent presentation. The first 3 questions are as follows. First one comes from Effie Mpande, asking what happened to the original SARS-CoV-2 virus? Second question comes from Bobaker. He's asking, once the virus has mutated to another strain, can the vaccine that developed against the original strain be effective against this new variant? And thirdly, Sandile Mbili is asking, how true is it that the virus is not curable but can be treated? I'm going to post these to you in the chat now so you can also visually see them. So over to you, Prof.
Thanks very much. So the original Wuhan virus essentially no longer exists, except in laboratories, because it has changed, it has mutated. There's a lovely story about the Chinese virologist who was boarding a plane, and the air hostess was telling him, or the air steward was telling him to please turn his phone off. And what he was actually doing was having a conversation to someone in Australia who said, can I please publish the genetic code of that original virus? And he said yes. And we are all very fortunate today that he said yes, because it was in him publishing that genetic code that the PCR tests for the virus could be developed so quickly, and that these vaccines could be developed so quickly. But of course, that original virus has traveled all around the world and has mutated, not terribly quickly, but has evolved into slightly different forms. And so the exact genetic material of that virus no longer exists. And we only have essentially mutated virus present all over the world. But as I've said, many of those mutations don't actually make a difference to how the virus functions, but some of them do, and those are the ones that we are worrying about at the moment. Importantly, we actually shouldn't really talk about these viruses as variants in a way, because all the viruses are variants. They're all slightly different from each other. In the UK, they talk about variants of concern or variants under investigation, but in a sense, they're all just slight variations which are normal in the population. The last question is, how true is it that the virus isn't curable but can be treated? I think what we do see is that most people clear the virus by themselves through their own immune system. So they will initially have replicating virus, and then they will clear the virus. And sometimes that period of continuing to have virus in their bodies can go on for a long time, but the period while they actually have replicating virus that is actually dividing and continuing to transmit is generally short, and is that 10 days, unless you have a situation where, like the examples that I showed, of people who are severely immunosuppressed, where they may continue to have virus replicating and continue to be able to transmit. So I think it is curable, but it's not curable by a medication necessarily that we give. It's curable in the sense that we ourselves actually clear the virus and then have an immune response. The only medication to date that's been shown to interfere with viral replication is remdesivir, and that needs to be given early to reduce the replication of the virus and therefore can shorten the course of the disease, but hasn't been shown to have a mortality benefit. And then the question around if the virus has mutated, can the vaccine still be effective? I think hopefully I covered that in the talk, but really that depends on exactly what the mutation is. So if it is a mutation that allows the virus to evade our immune responses, so a virus, if the mutation makes the virus look very different, then that will be something that means the vaccine might not work. So it really depends on what the actual mutation is.
Thank you very much for that. The next question comes from Marcia Zali, asking, does this mean that these vaccines may still be used since they're still able to provide protection against severe illness? Then Victor Mulangisi from the Katu Gazette in the Northern Cape is asking, does it mean as long as COVID-19 is within us, variants will keep developing? Can't it be possible to develop a vaccine that can fight all variants that develop? And then next question, the sixth one, or number 3 for this round, comes from Joan van Dijk from Bekesisa. She's asking, do we know whether SARS-CoV-2 will follow the law of declining virulence? And if so, does that mean variants that are more deadly, and then she mentions the B1117 and the 501YV2, according to a new preprint, will those be selected against eventuality? So let me just post those for you. There you go.
Thank you very much. So the first question is, should we still be using the vaccines because we can prevent severe illness? And that's really exactly why we are using the vaccines. To date, as far as I know, there is no clear evidence that any of the vaccines developed actually prevent transmission. There is some suggestion that some of them might prevent transmission, but the most evidence that we have is that they prevent clinical disease, they prevent people from getting sick, and certainly that the Johnson & Johnson and the Novavax vaccine in South Africa do prevent severe disease. Now, people having severe disease is a concern because it's obviously not nice for the person themselves, but it also places an enormous burden on the health service. And so the main reason that we're giving vaccines at the moment is to prevent severe disease, which will result in people being very ill, resulting in them needing to go to hospital, and result in death. And we want to reduce the morbidity and the mortality burden. So yes, we should still use vaccines because they can provide protection against severe illness. Unfortunately for the AstraZeneca vaccine, because they didn't have anyone who got severe illness in their trial, we don't know whether it could have prevented severe illness due to the variant or not. It's possible that it might have, but we don't know that for sure. And it was decided not to use that vaccine because of the data that showed that it couldn't prevent mild illness. In the case of the Novavax vaccine, the most recent results that I've just shared with you, the 55% effectiveness, were against both mild and severe disease. So that suggests that actually it can work both against mild and severe disease. And the Johnson & Johnson does seem to have effectiveness against both mild and severe disease, although less so than in the absence of the variant. The second question is, does this mean that variants will continue to develop as long as COVID is around? Yes, we think so. As long as there is transmission happening, mutations will continue to develop, and as long as we apply different kinds of selection pressure, different mutations will get favored. But we hope, as I mentioned, that the second generation multivalent vaccines might be able to, if not fight all variants, fight many variants, and therefore last for longer and give us immune protection for longer than the first generation of vaccines, which really only targeted the spike protein. And then in terms of the law of declining virulence, we don't know, but we do know that generally viruses will mutate to become less virulent. In other words, to be less likely to cause severe disease. And the reason for that is because, as I showed in the presentation, people who are severely ill are less likely to spread the virus. They're more likely to isolate themselves in their bed at home, or to be admitted to hospital where they can't spread, or to die where they also can't spread. And so that's not a very good survival strategy for a virus. That doesn't give it an advantage. The only situation where viruses will change to become more virulent is if the changes that make it more transmissible also make it more virulent, and the increased transmissibility outweighs the disadvantage of the greater virulence or the greater clinical severity of disease that they cause. Thanks.
Thank you, Prof. The next question comes from Kevin Brandt from Eyewitness News. He's asking, does it mean regular vaccine efficacy trials need to be conducted to keep up with the emerging variants? And then a second question from Kevin. He's saying, with waning immunity, does it mean immune pressure on the virus will decrease over time, but open people up to reinfection again? And then thirdly, Mia Malan from Bekesisa is asking about Moderna. She says, Moderna has developed a next generation booster that can potentially be used against 501YV2. The phase 1 study is happening in the US. Her understanding of the study is that the booster has to be given to people who had been previously vaccinated with Moderna. But it also confuses her. So she's asking, how will the people be exposed to the 501YV2 if that variant isn't dominant in the US?
Thanks. Those are all great questions. So ideally, yes, we would like regular vaccine efficacy trials to know whether vaccines will work against emerging variants. But that's firstly not particularly practical, and it's not always necessary. As we know with the flu vaccine, we have the kind of blueprint for a vaccine that works. And what we're able to do is to take the circulating flu strains that are around each year and to kind of plug those in to the blueprint of what works. And so we hope that with COVID, we'll be able to do the same thing. And we'll be able to show that if we take the same kind of vaccine mechanism, we can just change what the genetic material or the protein that we present to our bodies to make it develop immune responses to the proteins that are present in the variants. And so we wouldn't actually need to have an efficacy trial every single time. And also that we might identify what we call correlates of protection, so laboratory measures of the immune response that are a proxy for showing that someone is protected against the disease. And then without having to actually do a huge clinical trial, we can show that when we give the vaccine, that people do develop those correlates of protection, which shows that a vaccine is likely to work. So hopefully we don't have to do loads of trials because that takes time and because it's very expensive. The second question on waning immunity. So we don't know for sure how long immunity lasts. I think that's the first answer I can give. Yes, if we have fewer people who are immune, there would be less immune pressure. So your selection pressure for viruses that evade the immune system would go down, but people could then be infected by the original virus or a virus that looks similar to the original virus because that virus would then be favored. So the type of selection pressure would change, a little bit like the bark of the trees that changed color, and different viruses would be favored in the context of waning immunity. And then finally about the Moderna vaccine. So my understanding is that, so Moderna was a vaccine that was developed in America primarily for Americans, which is why it hasn't been used widely in other places, and it isn't on the cards at the moment for use in South Africa. And I think it's actually the 501YV3, which is the virus that emerged in Brazil, has also now been found in Mexico. And so obviously in America, there's a huge concern that if this variant is present in Mexico, there's a huge risk that it will rapidly become present in the US. And so they need a vaccine that can work against the 501YV3. So what they have done is in the booster vaccine, the messenger RNA, so the protein that is delivered to the body to develop an immune response, they have changed it in the booster to look similar to the 501YV3. And so that people will have the basic immune response, which would cover the wild type or the original virus, and then they will also develop antibodies and an immune response that will recognize the 501YV3 or 501Y in general, because 501Y looks the same, no matter which version of it you have. And therefore they will have an immune response. So even though they don't have a lot of 501YV2 in the US, there is a risk that they could have a lot of 501YV3. And that's why they're very concerned to have this booster that will potentially allow the vaccine to work against 501YV3.
Thank you, Prof. I only have one more question at the moment. I've just, while I'm reading to you now and while you're answering, if any other participant also, or a participant that already asked a question can also ask another question if he or she wants to, please post it in the chat because we will have a few more minutes for questions. So Prof, the question that I have here is from Effie Mpande. asking, what is the difference between a variant and a strain?
Thanks. That's a great question, and it's a question that lots of us ask ourselves a lot of the time. So a variant is really, as I've said, it's just a different form of the virus from the original, and really almost all viruses are variants. In the UK, they talk about these variants of concern, and these are viruses which are different from the original and which seem to, or which might have a different functional, be different functionally. They might do something slightly different. Once it's been confirmed that a virus is very functionally different and operates quite differently from the original, that is what qualifies it to be a strain. So and that's not so much transmissibility, but when people are very sure that it causes either a different type of clinical disease, different symptoms, or considerably more severe clinical disease, then we call it a strain. So at the moment, the international consensus hasn't reached that for the 501 changes, although there is emerging evidence in the UK that it is possible that this variant causes more severe disease. But we haven't quite got to the situation where we actually say this is quite a different virus causing different clinical disease to the original, in which case we would start to call it a strain.
Thanks, Prof. The next question comes from Kevin from Eyewitness News. It is already in the chat just now where we are, so I'm just going to read it from there. He says that in South Africa, some health experts said because the 501YV2 was the dominant variant during the second wave, we saw a younger cohort of patients also presenting in hospitals. Might this be because the virus is more transmissible, or can it be a hint that it is more virulent? And then he also says, also, can you explain what a lineage is in terms of the coronavirus family? Thank you. Over to you.
Thanks. I'll start with the second question, just because I think that's a little bit easier. So lineage really refers to the ancestry. So, for example, a lot of the virus in South Africa came from Italy, and that's its ancestry. And if we trace back the ancestry of a virus and the branching back, the branching as the virus changes, then those are called lineages. And when we kind of run out of space for more branches, then we start to say, okay, now we're making a new lineage. So the B, which is at the start of both the variant in South Africa and the one from the UK, B1.1.1.7, and the B1.351, that B is a lineage, the B lineage. And then as that changes, you add on more numbers to the B until you run out of numbers, and then you create a new lineage. So essentially that's really, the lineage is really about the ancestry, but it doesn't tell you anything about the functionality. So the Brazil comes from a completely different lineage. It's a P, even though functionally it's quite similar to our 501YV2. The first question is the issue of whether it's possible that 501YV2 is more severe. So a lot of people did feel like they were seeing more young people. When we've looked at data ourselves from the Western Cape and also nationally amongst all admissions in the country, there actually isn't any evidence that we saw younger people presenting in hospital. The age, if anything, we actually saw slightly more older people, or a greater proportion of older people in the second wave. And I think the clinical impression that people had of there being so many young people was just because there were so many people coming to hospital with very severe illness. And so it felt like there were a lot of young people, but it was largely just because there were a lot of people. In terms of severity, what's been shown nationally is that there is evidence now, even if you take into account differences in the age of patients, public versus private sector care, different provinces, and differences in the comorbidities, and you take into account the admission pressure that hospitals were under, so the number of admissions that they were experiencing, you take all that into account, there is evidence now, and there was a preprint published last week that shows some evidence of 10 to 20% increase in mortality in the second wave after taking all of those things into account. So that would suggest that it's possible that the variant is more severe, but it's also possible that taking into account admission pressure doesn't adequately take into account just how much more pressure the health services were under in the second wave, and so that we can't completely disentangle whether this is actually due to more severe disease or due to just due to the fact that so many more people were getting sick, and that put our hospitals under enormous pressure, and that we really didn't have enough in the way of critical care and ICU beds to cope with the numbers of patients that needed them. So I think that's something that we still need to tease out, and it's been very difficult to tease that out in South Africa, because what you need is large numbers of people who've had their virus sequenced, who present to hospital at the same time. So when the admission pressure was similar, when treatment protocols were similar, and then to compare their outcomes. And firstly, we don't test enough people in South Africa to be able to have be sure that we're testing a large proportion of all those that are infected, and then also to actually have sequencing on all those people to know who has the variant and who hasn't. In the UK, they're very lucky in some ways, because the PCR test that's used for diagnosis doesn't work in the virus that has mutated. And so without actually having to do masses of sequencing, they can figure out who's got the variant and who hasn't, and look at their outcomes. And that's really how a lot of the work that they've done that's shown increased severity has been done.
Thank you, Prof. We've got three further great questions. First one comes from Aisha Karim from Bekesisa. It says, since the new variants have increased transmissibility and therefore an increased reproductive number, what does this mean for efforts to reach herd immunity if the threshold could potentially keep increasing with new variants? And then two questions from Mia Malan, also from Bekesisa. First one is, why do scientists say it is easier to adjust mRNA vaccines than viral vector vaccines for variants? And then thirdly, when flu vaccines are adjusted for new variants each year, are there no clinical trials, or do they still get tested on small numbers of people? She's asking because she wants to understand how this will work with COVID-19 vaccines. Thank you. Thanks, Prof.
Thanks very much. The first question about variants of increased transmissibility, and therefore the reproductive numbers increased. And we know that the higher the reproductive number is, the more people that will need to be immune in order to interrupt transmission, to reach that magic herd immunity threshold, where the chance of an infected person coming into contact with a susceptible person is so low that we effectively interrupt transmission. So yes, with variants, that would mean that the number of people that would need to be immune is very high. And so that means two things. The first thing is that it means the number of people that we need to vaccinate is going to be very high if we have variants around. And it also means that even where we have populations where we have quite high levels of immunity due to natural infection, and I'm sure everyone on this call has seen the South African blood transfusion service study, where they looked at serology in blood donors and found that in some populations, 60 to 70% of people seem to have antibodies. That may not be enough to protect us against further waves of infection. And just as we saw in Manaus in Brazil, despite those very high levels of immunity, because of the increased transmissibility of the variant, as well as its ability to evade the immune system, they were still able to have a third wave. I think what's quite frightening in a way, or sobering, is perhaps the less alarmist way to put it, since I'm speaking to journalists, is to see just how high some of those immune levels had to be, the sort of 60 to 70% that we've seen after the second wave in that blood transfusion study. And that, yes, we have seen a curtailment of cases, but that even if it was herd immunity driving that curtailment, we had to reach incredibly high levels of immunity to get that kind of curtailment, and certainly much higher than we might have thought before. And that is precisely because of the high reproductive number of the variant. In terms of messenger RNA vaccines, so essentially the messenger RNA vaccines are made in a laboratory by artificially manufacturing the genetic code that you need for a particular part of the virus. So the current messenger RNA vaccines are really an artificial little piece of genome that codes for the spike protein. So if we have a mutation to result in a variant, what we can do is just to put a little mutation into that messenger RNA and it will code for the variant spike protein. So that's really easy. In comparison, the viral vector vaccines, you actually have to put the genetic code into a carrier virus, the viral vector, and you have to grow up that viral vector in a laboratory. And so to successfully grow up a viral vector with a bit of changed code inside it may be more difficult because it may not grow up successfully in a laboratory. And then lastly, Mia Milan has asked me a very difficult question because I'm not a flu vaccine person. So I actually don't know if the vaccines get tested every year on people. I assume that they do, but they certainly don't do clinical trials. So I'm assuming that they do, and that they do look for correlates of protection to show that there is a response. But I think the flu vaccine we've known for so long and has been shown to be effective, and that the mechanism is so effective that there is less concern each time that changing the proteins in the flu vaccine will cause it not to work, because we know the flu vaccine very well. Whereas I think for the first few changes in the COVID vaccine, we would at least want to know that they do work, at least by seeing laboratory responses. But it's a challenging balance between the wanting manufacturers to develop vaccines for us because we want the vaccines, but also not making the barriers so high by demanding clinical trials every time somebody changes the vaccine before we're prepared to implement it. So there's this, which is why it would be very nice if we knew, had some laboratory measure of protection so that we didn't need clinical trials every single time.
Thank you very much, Prof. I think there are two more questions. Let's take it one at a time, just see where we stand with time. First one comes from Aisha from Bekisisa, asking how long would it take to gather T-cell data about protecting the COVID vaccines? Could it offer, sorry, I've been reading it totally wrong now. How long would it take to gather T-cell data about protection the COVID vaccines could offer against existing variants? Sorry, Aisha, I'm not sure if I do justice to your question now. Prof, do you understand that?
Yeah, so I think Aisha's asking how long it will be until we know whether what the T-cell responses are to the COVID vaccines. What I showed today was antibody responses, and I said that we know that the immune system is more than just antibodies, and so we need to look at the T-cell responses as well. So there are a lot of people who are looking at that. T-cell responses are much more difficult to measure because you're not just measuring the product the antibodies that are getting produced. You actually have to look at how the cells are functioning, and you need cells. So you need blood that actually has cells in it, and you need to grow those cells and see how they respond. But there are people who are looking at that very actively at the moment, and so I think we will get answers on that relatively soon.
Thanks, Prof. And then the very last question for the evening from Effie. Why are rapid diagnostic tests less accurate when it comes to SARS-CoV-2?
Okay, so I think we're talking about antigen tests. So antigen tests essentially just look for one piece of the SARS-CoV-2 virus. And whereas what PCR tests do is they actually look for the genome of the SARS-CoV-2 virus, and they amplify up that genome. So even if you've got a very little bit of SARS-CoV-2, not a whole lot, because we amplify it up, we can then go and look, is there anything in the specimen that looks like it might be SARS-CoV-2? And that is why we find that often someone who's had COVID weeks later can still have evidence of some fragments of the SARS-CoV-2, because we've kind of amplified it up and found it, even though they're not shedding virus and are not infectious. So antigen tests are probably very good for identifying people who are currently infectious, because we're just looking for the antigen being present, but they are less sensitive. They don't necessarily identify everybody who has some virus in their throat or their nose, which is where PCR tests are better.
Thank you very much, Prof. Davies. That brings us to the end of the question and answers session. Professor Young, over to you for closure.
Thanks. So thank you. And now thank you to all the participants for the great questions that you've put forward. And Mary-Ann, thank you very much for your comprehensive presentation and for the detailed responses to all the questions. Thank you. So that brings us to a close for this evening session, and we look forward to see all of you on Thursday evening at the same time. When we will be having our final session with a focus on COVAX. So thanks and enjoy the rest of the evening. Thank you.
Thank you so much. Thank you. Bye. Thank you.
Bye-bye.
It's a big pleasure for us. Thank you.
Thank you.